All right. It is officially 11 o'clock. We'll give it just a couple of minutes as people trickle in. Welcome to the beginning of our HPN Awareness Week webinar series. We're so excited to kick off the week with this presentation. I'm going to give it just a couple of minutes as folks come in. I know people tend to trickle in a couple minutes after, so we'll just let everyone get situated. We have some housekeeping to go over, and then I'll give a brief introduction of our speakers, and then we will dive right into the content. Give it like just one more minute or so. Welcome, welcome. Awesome. Okay, folks will probably continue to trickle in for just a couple more minutes, but we will get started. So welcome, and thank you so much for joining us this HPN Awareness Week for a Vascular Access Deep Dive with the Vascular Guy, Dennis Wu, and Blaine Pantano. This is, like I said, the first of our HPN Awareness Week webinar series. We do have a host of upcoming events this week that you can still register for at oley.org/HPN_awareness_week. We have a webinar about bathing practices with Mary Galato. We have a super interactive behind the scenes of parenteral nutrition shortages webinar to talk about all the community efforts that are happening as a result of the past natural disasters that we've encountered. We'll hear from some of our long-term PN consumers, and then we'll hear from another interventional radiologist specialist in how patients can teach the experts what they need to know about our central venous access devices. So those are all still open for registration at that website right there. So please do sign up. We have a lot of great stuff planned this week. But without further ado, I just want to share a couple of housekeeping items. We're all probably very familiar with the Zoom format at this point. This is a typical sort of webinar format, so you don't have to worry about your camera or microphone. We'll only be able to see the presenters and their slides. And we won't be utilizing the chat or raise hand feature this morning just to minimize distractions. But at the bottom toolbar, you can use the Q&A function, and we will moderate those and share those questions as they roll in. They may answer some of them throughout the presentation. So as that happens, we'll just move them into the answered column. But please do share your questions. They're very excited to hear from you all. This webinar will be recorded and made available on our website at oley.org/webinars about a week or so after the presentation itself. And as always, just a reminder, the information provided during this and all of Oley's presentations is for educational purposes only and is not intended to be perceived as medical advice. Although clinical information is typically peer-reviewed, you are advised to consult with your healthcare team before making any changes to your own care. So without further delay, that's all the boring stuff. I'd love to introduce our speakers. So the Vascular Guy, as he's known on many a social media platform, Dennis Wu, is an interventional vascular access specialist RN with 5 years of experience in pediatrics and adult ER. His passion for educating clinicians and patients led him to social media, where he shares up-to-date information and fosters discussions about vascular access, aiming to improve patient care on a larger scale. He has some really great content, really awesome videos. He's very active. Check him out on TikTok and Instagram and all the places. And then Blaine Pantano is a nurse practitioner with over a decade of experience in the healthcare field. He is committed to providing exceptional patient care and advancing access to healthcare. Blaine spent 7 years working in various ICU settings, including cardiac, cardiovascular surgery, general surgery, and medical ICUs, and then 5 more specializing in interventional vascular access procedures. Today, he serves as a nurse practitioner on an abdominal transplant unit, as well as in the cardiac and medical ICUs, and aspires to ensure that others do not face the same hurdles in accessing healthcare information that he once did. So with that, I am going to pin our two speakers. Pardon me there, and I apologize in advance for my awful voice. And with that, I will turn it over to Dennis and Blaine. Thank you so much, guys.
All right, let's start sharing the screen. 3, 2, 1, and take that out. Okay, here we go. All right, so Vascular Access Deep Dive. I'm going to actually start out with Blaine, if you want to go ahead and get us started.
Sure. Um, so thank you for the introduction, Maisie. Like she said, I currently work as a nurse practitioner for a major medical center in downtown Houston. It's a level 1 trauma, and we do heart, lung, liver, kidney, and pancreas transplants. I typically deal more with abdominal transplantation, with kidneys, livers, and pancreas. But I do still cater to heart and lung transplant patients whenever I'm in the cardiac ICU. So the first thing I want to talk about is a really great term that they talked about in the Association for Vascular Access meeting this year, which is iatrogenic venous depletion. So this term iatrogenic, you may have heard it before, but it's a term we use as healthcare providers to describe a condition that's caused by medical examination or treatment, whether expected or unexpected. So when you sign a consent form and there's the potential causes of harm for that consent form, those potential causes of harm are what we consider iatrogenic. They're caused by us, not that we're doing it on purpose, but that the things that we do come at a cost sometimes. And unfortunately, it's at the cost of the patient. Recipients of organ transplants have usually incurred multiple hospital stays. And I'm sure this goes for a lot of the patients that are watching this right now, is that when you incur multiple hospital stays, you require vascular access every single time, and multiple incidents of vascular access is going to lead to venous depletion. It leads to scarring of the vessels. It leads to sclerosis or stricture and tightening, or the vessels becoming smaller over time. And so patients like this are typically deemed divas, or difficult intravenous access patients. And this is the population that I see. These patients come with chronic diseases, and it's unfortunate that over the course of their hospital stays, it just becomes harder and harder to access over time. So another thing I want to talk about is this is specific to kidney patients. But when you have end-stage renal disease, another complication that can make venous access on a patient much harder is something called vascular calcification. So when you have kidney disease, the kidneys usually take care of a lot of the distribution of electrolytes in the body. And through a complex active process involving a lot of regulatory proteins, complicated jargon, this process is how bones form. And unfortunately, this process of bone formation, these proteins end up expressing on the outside of blood vessels, and it leads to essentially bonification, or like a calcification. We call it ossification, or like the process of creating bone. And that happens inside the vessel walls of these kidney patients. And the longer that you have kidney disease, the more that this happens. And unfortunately, even after transplantation, this process does not reverse. So whatever damage is done, it stays for life. This leads to difficulty puncturing through vessels, especially in the arterial system. But in both the venous and the arterial system, it can become a problem. So one of the things that I stress to my team, and that I've always stressed through my career in interventional vascular access, is we think about the immediate, but we need to be thinking about the future of these patients. This is not their only hospital stay. It's not going to be their last hospital stay. I wish it was, but these patients are going to incur more hospital stays. And so what do we do after transplantation? The life of a kidney transplant in a living donor is 12 to 20 years, whereas in a deceased donor, it is 8 to 12 years. And though preservation may not be an immediate concern for most people, we have to consider the life after a transplanted organ has met its end. And so these patients, after the transplanted kidney dies or has met its life cycle, these patients are going to need access for dialysis again. And if we have depleted their vasculature by repetitively poking them in places that we should have considered poking otherwise, it can lead to patients not being able to get grafts or fistulas. The unfortunate thing about that is that grafts and fistulas are studies show that grafts and fistulas are much better for dialysis patients in the long term. Kudoki guidelines, which is it's a big set of guidelines for kidney doctors, talks about patients in their first year of hemodialysis that start with a tunneled dialysis catheter rather than a fistula or a graft have a much higher increased risk of mortality within the first year, or risk of dying within the first year due to complications of that tunnel dialysis catheter. It leads to higher infection risk, complications of the catheter itself. So I encourage you as patients, but also my fellow clinicians to think about vessel preservation. It's usually at the back of our mind, but it's something that we need to consider. This one's kind of a special consideration. I've only run into it a couple of times, and not many clinicians will actually know this. And in fact, I brought it up to a few clinicians that don't typically work transplant, and it's the first time they're hearing of it. So typically when you transplant a kidney, it's transplanted into the lower right pelvis. And this picture on the side kind of shows you. So native kidneys sit up high in the abdomen, somewhere around the bottom of your ribs, whereas a transplanted kidney sits kind of below your hip bone, kind of in this pelvis space. And when you place a temporary dialysis catheter on the same side as a transplanted kidney, typically when we're putting in a femoral or a groin access temporary dialysis catheter, the typical length that you'd choose is a 20 centimeter. It gets you exactly where you need to go. But with a transplanted kidney, if you stick a 20 centimeter dialysis catheter, you're going to be right into the venous outflow of the transplanted kidney. And when you start doing dialysis through that temporary dialysis catheter, you can actually interrupt the flow of the transplanted kidney. And so it's actually standard of practice to, if you're placing a temporary dialysis catheter on the same side as a transplanted kidney, to choose a longer, which the only length that exists longer in a temporary dialysis catheter is a 24 centimeter. So that's something as patients you need to keep in mind. So if you're ever in a situation where you're having issues with your transplanted kidney and they have to put in a temporary dialysis catheter and it happens to be on the same side as your transplanted kidney, you can say, hey, wait, stop. What size is that catheter? Or what's the length of that catheter? Because this could be compromising the flow of my kidney, of my transplanted kidney, which if you're having a temporary dialysis catheter place is already having problems of its own. But
And
like I said,
this is only for femoral dialysis catheters.
correct. Yeah, it's only for femoral dialysis catheters, but it's more than that. It's not just femoral. It's femoral on the same side as the transplanted kidney. It's kind of like like I said, I've only seen it a couple of times but it's enough times that I feel like it's something that it should be brought up. Um, it's
So
not something that's out of the realm of possibility.
so just remember where that kidney was placed, left or right.
Yeah. So typically transplanted kidneys are placed on the right side unless there's some sort of anatomical uh, obstacle to placement on the right side.
Cool. All right, appreciate your time, Blaine. Blaine's got to head out. He just got off a night shift and he stayed awake for us. So we're
I'm
gonna
happy to
let him
answer
go.
any questions if there are any Q&A questions. I'm happy to answer them before I uh, go to bed though.
And it's his anniversary, so happy anniversary, Blaine.
Oh, thank you.
Hey, anybody have any questions for Blaine before he hops off?
I think this could be for either of you, but we had somebody ask, does a patient need to be awake when a PICC line is pulled? PICC will be pulled and a Hickman placed under light sedation. They keep getting conflicting information. So you're welcome to answer that a little bit later on if it makes more
Cool.
sense.
No,
And then, oh,
I,
somebody else
I
just asked, are there any other catheter length considerations with any other types of transplants? We typically have some more digestive system transplant recipients
sure.
in our population.
So, as far as I know, there are no other considerations for length of catheter in terms of a transplant. Catheter length consideration should always be something that's taken into account on the size of the patient, the site that's chosen for access. That's typically something any clinician should know. But the special consideration for this one is just really particularly for kidneys, and it's because of the new vasculature that is created for that transplanted kidney is right where a 20 centimeter dialysis catheter would sit. Um, as far as the PICC line question, patient doesn't have to be awake when a PICC line is pulled, but I can tell you that having a PICC line pulled in the many PICC lines that I've pulled in my career, it's not a particularly painful procedure. It feels like some pressure as it's being removed. I've had patients report it as kind of a funny sensation just because you're pulling a very long catheter out of an insertion site. But typically when a Hickman is placed, a Hickman's more of a tunneled catheter, and they will, if you're having it placed in an interventional radiology suite, they do what's called moderate sedation, which they'll give you a sedative medication that'll keep you kind of in a twilight state, like kind of you're not going to care what's going on. They use a medication called Versed, typically for moderate sedation. It just kind of keeps you comfortable during the procedure. But no,
Uh,
typically being awake for a PICC line is very standard for a PICC line removal. Oh, and
so
for placement too.
I'll do a little deep dive. So Blaine, you're more than welcome to stick around.
Sure.
But so let's and I hope you don't mind. Do you mind if I put the Q&A up? It just helps me to remember which question was asked, so I don't go on a rant and off topic.
Yeah, that's fine.
Amazing.
Yeah,
Okay,
as long
cool.
as you're good with that.
So so Blaine's absolutely right. You don't have to. I think there's a lot of people here who have dysautonomia or some kind of issues. Actually, can you guys raise your hand? Raise your hand if
Hand raise is disabled, Dennis, I think.
oh, hand raise is disabled.
Yeah.
Darn. Sorry, I like to use all my interactive features. So, for some of those who have low sensitivity to local anesthetics, then sedation is highly recommended.
Oh, they
Oh, they
can raise their
can.
hands. Yeah,
Yeah,
she's.
yeah, yeah.
I
Let's
thought at the
go.
beginning they were saying it was disabled. My bad.
Yeah,
How
we
many
tend
for
not to
how
use it
many?
during webinars, so
No, let's do it. Let's change. Let's shake things up a little bit.
And Dennis is
So I
very
want you to
extra.
go
He's
ahead
going to
and
use all the tools.
every tool I can get. Raise your hand. Let me see if I can see it. Yeah, raise your, oops, maybe not. All right, so I want you to just raise your hand if you have issues with sedation or local anesthetics. Usually people with dysautonomia, from what I've found, or autoimmune disorders or GI disruption, they tend, and of course our redheads, they tend to have issues with anesthetics. Like they need higher doses, stronger doses. And so what we do is sedate you as best as possible because it will be extremely painful because we have to tunnel out from the initial insertion site out through oh, did I press something wrong?
no, I just paused your screen sharing just because I there was a lot going
Oh,
on.
appreciate it.
So I
Thank you,
just
thank you,
wanted to be
thank you,
able
thank
to
you.
focus on you.
No, no, thanks, thanks. And so there's skin tracking from under the skin that we have to take a rod and shove it through under your skin. We'd rather you not feel that. And so what I would do is lidocaine you all the way. If it works for you, I don't need to sedate you. But if we have known issues of the lidocaine or bupivacaine not working, the local anesthetic not working, then yeah, we'll sedate. on the patient whether we will or not, but I have tunneled long-term catheters without needing to sedate. So it just depends on the patient. Difference between tunnel catheters and non-tunnel. All right, let's
I
get
can tell you
into
that
it.
if you are having it placed in a interventional radiology suite, I have done some work in interventional radiology, and typically if you ask for sedation, they're more than happy to be liberal with it.
They don't want you
Dennis,
awake.
I think we have the echo again.
Oh, let me change that. There we go.
At least I know, me personally, as a clinician, when I'm placing lines, if a patient says they're nervous about the line or anything like that, and I always offer sedation if possible, and then especially if a patient asks for it themselves, like, I don't have any issue giving sedation. I'm more than happy to be as liberal as possible with the sedation, because at the end of the day, if whoever is having the line placed is comfortable, I'm more comfortable.
Yep.
So
The original machine had a base plate of prefamulated amulite, surmounted by a malleable logarithmic casing. What? In such a way that the two spurving bearings were in a direct line with a panometric fan. Okay. The lineup consisted simply of 6 hydrocoptic Marsal veins, so fitted to the ambifacient lunar wane shaft.
I love this video.
My apologies.
All right. So, look, when we talk about this stuff, it can get pretty convoluted, and please stop us. I apologize.
Blaine.
All right. See you, Blaine. Appreciate your time, man.
no, thank you, and
and-
thank you everybody for listening and everything, and thank you for having me.
Of course.
I'll share
Good
Blaine's
night.
email if anyone has any additional questions. We can forward those along.
Yeah, please do.
Yes, please. So it can get pretty convoluted. And how many of you have, while you're at the hospital, they explain things to you, and then when you go home, you're like, what the hell did they say? I completely forgot. So we've created this tool called IntraCav, and more than welcome to give it a try. We've made this clinician focused, but you can actually ask it to speak to you as a patient, to dumb it down for you however you want. It's called intracav.ai. It's an AI chatbot based on Vascular Access. It's contextualized, but it can actually answer a lot of clinical questions for you guys thoroughly, and it can reverbalize things to make it simpler for patients. So just ask it to say, hey, I'm a patient. Do you mind dumbing things down? Here are my questions. And then it'll answer you with all the guidelines and standard practice that we fed it. So that's just a resource for you guys. All right, so some things to consider. I'm not going to go through all of this. You will have this available for you. I will print this out and give you an online version of this, and Maisie will have the link to it for you guys to download for yourselves. But things I want you guys to really focus on is this vesicant medications piece. This right here. This is the part that's really well ignored, and this is also why we need to give you these long-term catheters. So these are some considerations that we have before we decide which catheter, which procedure, and where to place it. And this is just an extensive list of vesicant medications, and I'm sure you guys are familiar with this one right here. So here are the catheter types. Someone asked the difference between tunneled. Here it is. This is a regular centrally inserted central catheter. It's also known as CVC. It's CICC in the academic research world, to be more specific, but you'll hear it as CVC. So this is what goes into our internal jugular. I'm sure you've seen these with temporary infusion treatments. And what we do is we access from that port, from that part of your neck, and we tunnel it under your skin. So it goes under your skin, and then finally it pops out into a better spot. The reason why we don't like it to come out of the skin at the neck is because in your neck you have 1, 2, 3 axes of motion. What does that mean? With all this movement, that tegaderm, that tape, is going to come off of your neck more easily. When that hole, that insertion site, is exposed, that's when junk can get in and start infecting your skin and then seep its way into your veins. And then it becomes a bloodstream infection. And so we're trying to avoid that. And to do that, we put it in a spot where it's far away from your bloodstream, but also in a flat surface where no matter how much you move your body, it won't disrupt or pull away at that dressing. Here's a picture of a PICC line versus a mid line. I'm sure you guys have heard of both. So the PICC line goes from your arm into your arm all the way and follows a track of your heart. And this is called the cavo-atrial junction. Basically where the vein and the heart meet, there's like a little hazy part where they both merge together. And that's where we like to put the catheter tip for all central venous catheters. So PICC line is under the umbrella of central venous because we're in the center of the body. Midline starts at the arm and goes to about the axilla and right about here in Europe and here in the US. We keep it here in the US because of lots of neglect, and we're going to talk about that. I'm going to call out my own colleagues out here. Due to severe neglect and at scale, and we don't know how to identify symptoms of complications like clotting or thrombosis. We've deemed it safe to put it here, but unsafe to put it up here because we're ignoring at scale, we are ignoring the complications, swelling, nerve pinching, pain, all those things. We're telling the patients that it's normal, it's normal, it's normal, ignoring it, and then patient gets worse. And there's some long-term complications. So we said, all right, well, let's dumb it down and end it here. Whereas in Europe, they've accepted it to be around here. And so that has been a big debate about where it should terminate. And it really should be up to the clinician and their clinical judgment. Any questions so far? Sorry, I can't see any of the Q&A.
I don't see any questions. I did want to let you know your video is still kind of in stereo if you want to slide it back. It's just not that we don't
There
love
we
seeing
go,
you
thanks.
twice, but you're good.
I appreciate that. So extended dwell PIVs, I'm sure you've heard of extended dwells, long dwell catheters versus regular PIVs. Extended dwell is not an academic word. It is a marketing term that basically just means longer PIV catheter. That's it. There's no like hard definition that we all agree on what is considered extended dwell. Here is a brief description of what they're selling us and how they're marketing it, but just know that extended dwell is just a long PIV. And I want you to get this part. IVs do not mitigate risk for CLABSIs. I'm sure you've heard of central line bloodstream infection or bloodstream infections. The PIVs are not a strategy and should not be a strategy against it. So people say, oh, we're going to take out that central line to avoid bloodstream infection. We're going to put a PIV instead. That's not a good strategy, and that's deemed by the CDC and INS that we should stop treating it that way. So this is just a little bit of information to arm you guys to protect yourselves from bad habits and bad policies. What are midlines? So these are the type of midlines you'll see, and this is where the confusion happens. You'll see a full, like a PICC line looking catheter, or you'll see a regular PIV looking catheter. The nitty gritty of a midline is basically it just ends at your shoulder. That's it. Ends at your shoulder or before, and then above your elbow. PICC lines, we've talked about that. Central lines, we talked about that. And you'll have all this to digest later as well. I'm sure you guys have seen hemodialysis catheters. We generally put it in the right neck. We will put it in the left if we have to, and then the legs will be the last resort. Of course, these are for dialysis. And here's the tunneled. Okay. So, common device issues. How many of you guys have seen these? And how many of you were told this? Between the silver discs and the CHD discs. The silver disc doesn't work when it's dry. It doesn't work as well, I will admit. It is better for the silver discs to be wet. The efficacy is significantly more. However, it is doing something. And the reason why I mention this is if the nurse had accidentally forgotten to, or you forgot to apply saline or water to that disc and you put it on, it's okay. It's not worth disrupting that dressing and adding more time of exposure to things possibly going into that insertion site. The silver will start to activate with your sweat, with the moisture of your skin. However, it is significantly more and better delivered with some kind of saline or sterile water. Chlorhexidine does not need to be wet. In fact, do not wet your chlorhexidine discs. Please don't let them do this. And if they do, ask them to replace it with a new one. It does not increase the efficacy. All it does is make that moist and possibly interfere with the CHG. They don't recommend wetting it beforehand. All right, so what are the truths about silver and CHG? Silver, wet with saline water, yes. With silver discs, and I'll show you what they look like. And then the dark silver side must touch the skin. How many times have I seen in these posts on social, but also when I walk into my patients' rooms and their houses, and I see that silver side not touching the skin? That dark part needs to touch the skin, or else it's not working. You have to have that dark side touching the skin. And the slit needs to be right under the catheter. We'll talk about that too. I'll show you that video. CHG, usually your bio patches, your Gardivas, they'll have some kind of label on there with their logo name. If you don't see that, it might be upside down and it's not working at all. So you want to make sure that you can see and read the label, because if you can, then the sponge side, the CHG side, is actually touching your skin. And then again, you want the slit right under the catheter. I'm sure you've seen it rotated where the slit is pointed a different direction. I'll show you why that's not good. So this is a silver disc. Do you guys see that dark side? This is the silver. This is the active ingredient, and it's not touching the skin, so it's not actually working. Now, this is the bio patch. You can see the label. It's flipped properly, but do you see this slit over here? I want you guys to raise your hand. How many of you have seen that slit pointed this way, or that way? That is incorrect, and that's that's going to increase your risk for complications, and I'll show you a video of what complication.
Okay, so a lot of people are putting these wrong because they don't understand what these are. So I'm going to go over this real quick so you can keep your clinicians accountable, clinicians, so you can improve your practice. This is a chlorhexidine disc. They're a lot thicker, and they contain a certain amount of chlorhexidine inside this sponge. This is not a sponge. This is a silver disc. It's called Silverlon. They make these silver activated antimicrobial discs. The difference between these two is that the sponge side that does not have the design or the print must be facing down on the skin itself. This is how you properly apply it. Not like this, not like this, not like this, but with the catheter right above the slit or on top of the slit. You do not want this to be hooked in, because when you're removing the dressing, it will actually hook in the catheter and then pull it out. So you want this disc, the sponge side, the non-printed side, to be facing down on the skin so that it's delivering the CHG in that insertion site. Now, this is a silver disc. You want that silver side facing down. You do not want it facing up, because the silver is what's delivering and activating the antimicrobial action. If you apply it with the silver side facing the skin, it will activate, and there we go. Wait a second. There it is. So it will activate and kill the bacteria on the skin. If you see this dark side up, it is doing nothing to protect that insertion site, because the silver needs to be touching the skin. This is not a sponge. There is no silver elements delivering over time through the sponge. This is only delivering the silver ions when it's actually touching the skin. And again, you want that slit to be right next to the right under the catheter line.
So I hope that makes sense, and let me show you an example of why that slit placement is important.
Or pin site with the CHG
And this is
impregnated white foam side in direct contact with the patient's skin.
this is the
Make sure
manufacturer's
that the
video.
biopatch is not laying on top of the catheter hub. When aligned properly, the pre-cut slit allows for an easy release of the catheter when the transparent film dressing and biopatch are removed. In order to ensure easy removal when used with the film dressing, place biopatch around the catheter in such a way that the catheter rests upon the slit portion of the biopatch. If the slit is not properly aligned, the catheter can become trapped between biopatch and the transparent film dressing. To maximize efficacy, make sure the edges of the radio slit are touching and the biopatch is in contact with the skin to achieve 360 degrees of...
So, of course, we see here without the label, and so it's put on improperly. All right. Any questions so far?
Yeah, we do have a few. So going back to when you were listing the devices, somebody asked, you did not include a port. Is there a reason for that?
Ooh, a port? Are you
Yeah.
saying, oh, for CVCs? Yes, a port, we're going to go over a little bit later. The thing about the port is there's so much more complexity to it because of the way that the device is made. One trick that I do want you guys to be aware of is that actually, you know what? Let's talk about it. A port is basically a tunneled catheter. It's the same thing. We do the same exact insertion, same exact tracking, subcutaneous tunneling, and instead of the catheter coming out of your body, we make a little pocket, a subdermal pocket, under your skin, and then we place what's called the port. So the port is that little reservoir, little rubber stopper pouch with liquid and space for medications to go through as well. The reason why we like the port is because it's a very low risk for infection. Not that it completely eliminates. I'm sure some of you had infections with ports before, but it does significantly reduce the risk for infection because we don't have a break in the skin at all times. You can take showers, you can go swimming. When it comes to quality of life, it is a lot better if it works out for you. So let's talk about it. And I do apologize that I didn't put in the port. I thought it was going to be we're going to run out of time, but since you guys asked, let's talk about it. With the port, with those of you who have connective tissue disorder, dysautonomia, listen to me. If you have connective tissue disorder, you have a higher risk of that port flipping. Yes, it is a better lifestyle. Yes, you have a better quality of life. However, there are considerations, and we as a community, a healthcare community, we still cannot figure out or are trying to figure out how to best accommodate that port. Because you're also a high risk for infection, we want to make sure that that port stays in there for a very long time. However, those putting it in may not be aware of your condition or know how to deal with your condition. So it is very difficult when you have weak connective tissue or some kind of connective tissue disorder, because usually we put it in the pocket, it gets anchored, and over a few weeks it heals and it anchors it down. The scar tissue anchors down the port into the skin, into the subdermal layer. However, for those with connective tissue disorder, we know that you guys don't heal properly. Well, you guys know. I don't know if we know, but you guys know that you don't heal properly. Unfortunately, a lot of the clinicians don't. And so when they're putting it in and they don't know or understand how to deal with your connective tissue disorder, they'll make a nice large pocket to make it easy to fit in there. However, that large pocket, if it's not snug, it has more room for you to flip that port. And those are things that even IR and vascular surgery are not considering because it's not well studied, it's not well known. And so we don't know what the tips and tricks are to make it better. The best recommendation that I've heard was make it a super tight pocket, no matter how inconvenient it is for the inserter. Make that tight pocket and tie a really tight suture. And of course, you guys know that the sutures don't work well either. So for those of you with connective tissue disorder, this is very difficult to manage and very difficult to figure out. So my recommendation is a tight pocket with the glue instead of sutures, because sutures will just basically just grow right out of your skin, and it doesn't hold very well. So just keep that in mind. Make sure that you're well educated on your connective tissue disorder and the likelihood of that port flipping, and communicate with your clinician who's going to insert. Make sure they know ahead of time. Hey, by the way, just to let you know, I have connective tissue disorder. In my pathology or in my disease community, our ports flip very frequently. Could you please look up and research and figure out what the best way is to reduce that port from flipping? Now, hopefully they'll do their research, but you cannot control what they do or do not do. However, there is something that you can do if you get that port to prevent that from flipping. Let's say I get a port on my right side, and can you guys see my video of me? Or do I need to?
Nope, your video's off.
Okay, so I'll move over to the Zoom.
I think if you turn your video on, but it's slid over in your slides like it was, it works.
I see. There we go. Boom. All right, there we go.
Oh,
So
and then yeah. Remember how you did it with when Blaine told you? Yeah, there should be
there,
arrows that like push it over.
perfect, perfect. So for
I don't know what's going on. Sorry.
no, you're good. I'm just pressing stuff. So when you have a port on this side, you want to limit the mobility and how much you move and activate your range of motion during your ADLs, your activities of daily life, whatever you're doing after that surgery or after that procedure. You want to make sure you're minimizing how much you're moving this part of this upper arm. You want to try to do everything with the opposite side. Why? Because for you guys, you don't heal as well or as quickly as you know. And so you need to give that time to heal, which means you got to keep that arm very still for a very long, almost like you just had shoulder surgery. You don't move it. Put like the arm sling and just remind yourself not to move that arm. It's not that it's going to damage anything. It just possibly will make things move inside that pocket more frequently with the more activity you have on that side. So after you get that port, it is going to be your responsibility as a patient to try to minimize the amount of movement so that that site and that port has time to heal, and that scar tissue has that slow delayed time and enough time to heal over that port site to make it stable.
Somebody just asked how long approximately, I mean, obviously it's going to vary patient to patient, but ballpark, how long to limit that range of motion?
Oof, we don't know. Because every patient's connective tissue disorder varies. It's a huge spectrum. That's something hopefully your clinician will have a better idea about, but there's no research on this. There's no solid data. Let's say, what's the standard time that it's supposed to adhere? For a tunnel catheter, for this one, we say about after 6 weeks, you're good to do whatever. You can even take off that dressing. 6 months, even better. However, I've seen patients with dysautonomia and connective tissue disorders where that thing slips out after 4 months to 6 months. It like just drops out because they were told it was safe to remove. So we don't know. That's the answer. I wish I had a better answer, but there's, as you know, with these connective tissue and dysautonomia, there's very limited research to give you a definitive answer. But I would say give it whatever time they tell you to keep it immobilized, double that, and give your body a chance to adhere to it. That's a really good question. Yeah.
We have a few more questions.
Yeah,
if you
let's
don't
go for it.
Under what circumstances would you personally have a midline placed, or would you avoid them and only have a PIV or CVAD?
Ooh, that is a fantastic question. It depends on the treatment and it depends on my vasculature. Let's say this. I think midlines are the most complicated device to consider not necessarily to insert, because we are very blind when it comes to information. We have very little idea how many valves are here, why the midlines are failing, how to mitigate them. In my opinion, remember, this is opinion, there's no research to back this up. I don't think there's ever going to be research to back this up. A midline is a financial tool, not necessarily a clinical tool. Yes, it's a clinical tool. However, I think hospitals and healthcare leadership has misused midlines to avoid central line bloodstream infection. And if we have some time, we'll talk about the politics of the hospital setting and what you guys need to do to protect yourselves from these bad politics and bad policies. Central line bloodstream infections are very expensive. They can cost a hospital anywhere from, I don't know, $9,000, which is unheard of to be that low, but about $9,000 theoretically to over $120,000, $150,000. It's very expensive. And I'm not going to go, well, yeah, let's go into it. The hospital gets paid usually what's called through a DRG system, so diagnostics. So depending on your diagnosis and how many diseases you're diagnosed with or treatments that you need, the insurance company says, okay, for these diagnoses, we'll pay you $20,000, $10,000, and $80,000, and that's it. If you scan them 6 times, we're not going to give you more money. If you do 4 surgeries, we're not going to give you more money when they only needed 1. If they come back, if they get discharged too early and they come back with the same problem after a certain amount of time, within a certain amount of time, we don't give you that money back. So there's a lot of things. So if the patient stays for longer because they got sicker, you're not getting any more money from that. So they're stuck with a fixed amount per diagnosis, per disease. And so giving you that central line bloodstream infection is a huge money loser for hospitals. So they're trying to avoid that. The problem is, right now, even if we infect you with the PIV or a midline, because a midline is a PIV, we will not lose money for it. You hear me? We're not going to lose that reimbursement because currently midlines and PIVs are not non-reimbursable. So they don't get in trouble for it. Now that's about to change. Now how the hospitals react to that, I'm a little terrified of what's going to happen, what kind of loopholes they're going to try to find. But a midline is basically a loophole for a lot of people. And so when you needed a central line or a PICC line, they decided to give you a midline instead. So just keep that in mind when contextualizing this conversation right now. I would want a midline sometimes. I don't think we always need a central line that goes all the way to the heart. And so it depends on what medication, how long am I going to get that medication, and what does my vasculature look like? Is my vein really small here? Is it super small right here? From here to here, is that very small? If it is, I'm going to want a PICC line. I'm not going to want a midline. I'd rather have a PIV. And then if I have optimal vasculature, the forearm will do better than a midline sometimes. So it's a very complicated question to answer. I hope that answers thoroughly. It depends on the patient. It depends on the treatment and the duration. But I would not, sometimes in certain circumstances, I would want a midline instead. So let's make up a circumstance. I'm only needing medications for a week, maybe 2. I'll push it to 2 weeks depending on the meds. The medication, when I researched it, has a low osmolarity and has a very neutral pH. Then I will opt in for a midline. Sure, let's do a midline. If it's a 2-3 day infusion of anything, give me a PIV in the forearm. I don't need a midline. If I have no veins in the forearm, then give me a midline in the upper arm. If I'm obese or I lost a lot of weight, then give me a midline because I want that length to be able to stay in my veins and not come out because of a shorter catheter, PIV catheter. Any other questions?
Yeah, we have
Let's go for
We have a couple about the silver discs and the
it.
patches.
Okay, let's do it.
So someone was just clarifying to squirt the silver disc with sterile saline before applying the dressing. I know you mentioned that, but just for clarity.
They're asking if they should squirt.
Well, wet it with sterile saline.
Yeah, sterile saline or sterile water. Sterile, that's the key. Sterile liquid.
Okay. And then are there any concerns for people who don't use either of those method or either of those patches if they have long-term catheters?
What would be the alternative? Are they using some kind of antimicrobial?
I'm judging by the question, I'm guessing no. So probably
Okay.
just dressing.
If there is no antimicrobial device, then yes, there is a concern for increased risk for infection. There's something called catheter pistoning. Let me see if I have it.
So, okay.
Okay.
There we go.
Bacteria will invariably attach to the catheter surface as it passes through the skin layers, hair follicles, and sebaceous glands. All surface
So
bacteria
can
will
stop it.
invariably attach to the catheter.
What happens during dressing changes, and this is happening, by the way, we are carrying bacteria with every insertion, just a little bit, but every insertion, there's some amount of bacteria being put in. So for those who think that a midline and a PIV is a hedge against central line bloodstream infections, every time we poke that PIV, we're dragging bacteria every incident. So there's a thing called catheter pistoning during the dressing change that does make me more concerned for those who are not using any antimicrobial device. Let me see if I can find that. Here we go. This was a video sent to us by a colleague that said, we're very proud of this video. This is the best dressing change we'll ever have. I want you to watch how much that catheter is going in and out. There's our marker.
After preparing the skin with a skin protectant pad, fix the CVC with a sutureless securement device.
Just from handling, just from even pressing the skin during the cleaning and releasing that pressure causes that skin to move. Even if that catheter wasn't moving, that skin is going in and out, let alone the catheter going in and out. So every movement forward takes what's on the outside, drags it in, takes it, drags it in, takes it, and drags it in. And so that catheter pistoning is a huge risk for infection, and we want to prevent that. And we want to minimize the amount of microbes that are growing around that skin. So yes, there is a significant increase if you have nothing. And so there are strategies around that. If you have allergies to chlorhexidine, use silver. If you don't have silver discs, use silver alginate dressings that have silver in it, cut it up, and then use that instead. Now, whether you can get that resource or not is a whole different issue. We're not going to go into that just yet. Good question. Anything else?
We have about 5 more.
Let's do it. Let's go.
Okay. If you have a CVC inserted directly into the heart wall, can it just be removed like any other CVC?
No. Heart wall. Hold on. Let's say that again. Directly into the heart wall.
Yeah, I think this
There-
is kind of an odd
That's a
case.
great question. Theoretical, that will never happen. No one will ever poke directly into the heart to access your largest flow rate. So the reason why, let's talk about this for a second. The reason why we end at the cavo-atrial junction is because that's where the most amount of blood is flowing. At about 5 liters a minute, we're pumping so much volume, the damaging properties of the chemicals are diluted. It's called hemodilution. So the blood essentially dilutes the medication, so the medication concentration doesn't damage the individual cells immediately when it touches the veins. So think about a lemon drop. If I put a drop of lemon in my eye right now, pure lemon juice, it's going to burn like crazy. However, if I put it in a gallon of water, that drop in a gallon of water, mix it up, dilute it, take that water and put 1 drop in my eye, it's not gonna burn. I'm barely, or if at all, going to feel that lemon juice. And so we want that medication to be diluted so that the acidity, alkalinity, or the osmolarity of the medication doesn't damage your vessels. But never will you ever see anybody poke through the heart. That'll interfere with the heart's function. It'll kill you. At least not that I know of. I don't know of any treatment of anyone puncturing through the myocardial tissue.
Okay. Next one. Is it true that TPN does not completely flush from a port, increasing infection rate?
Ooh, this is a tough one. Uh, Possibly, yes, but I think the studies that have come up with those risks for infections did not take into account the direction of the needle bevel. What does that mean? You know what? Let's do this. Let's look it up. So the needle bevel, I'm sorry I didn't have this one prepared, but this is a really good question. Port needle bevel. Can you guys see my screen?
Yep.
Okay. Your needle bevel needs to be pointed in the right direction. Do you guys see? Here we go. Do you guys see this image? I'm going to say VacuFirst is a great resource for those who are looking. Do you see where the opening of the needle is pointing?
Yes.
It's pointing towards the catheter. That's going to give you the least amount of cleaning or shear force around to wash away that port. So you want your port needle, the bevel opening, to be directed away from the catheter. So if my catheter is lying like this, I want my needle facing this way so that the fluid is pushing it out away from the catheter, the opposite direction of where the catheter is lying. Do you guys see that? So what we don't know is which one are your nurses doing in that study. I have a feeling that if this patients with this direction of their needle bevel have better outcome. Theoretically, remember this is just an opinion, but theoretically, I think these are able to wash away that TPN properly. The problem is we don't know because we're not recording, we're not documenting in these studies what the nurses are actually doing. This, or this. And so those studies with any of these, especially these two, I would say you're a high likelihood of getting that port infected. And actually, let's look at, and this is the opening of the needle bevel that I was talking about. And so the direction of your needle bevel makes a huge difference. Port infection, port gunk. There we go. Inside that septum, there's all that buildup of protein and lipids and everything else that you don't want in your body. And so, yes, when used improperly, but with the optimal practice and care maintenance, I think we can significantly reduce that risk. But yes, TPN is full of protein, full of bacteria, or sorry, not full of bacteria, let me rephrase, full of nutritious yummies for bacteria to grow with. And so you want to flush diligently with TPN use. For those of you who have the double lumen catheters and the ports, I wish we had the comment section. Would we be able to open up the comments a little bit? Do you mind?
For the sake of time, I'm going to say no.
No worries. So you want to flush with more than 20 mLs, more than 2. I would say if you're not fluid restricted, flush with 20 to 40 mLs, if not more. Be very liberal with the amount of volume that you're flushing so that you can wash away all that protein, all that junk. It's a good question. I'm gonna go into a couple more videos and then we'll go back to the Q&As.
Awesome. We are at time, so if folks have to go, you're welcome to hop off. But I know Dennis is more than happy to stay on and keep going and answering questions. So totally up to our participants, but we'll be on for a little while longer.
So I'll be on for at least another 30 minutes, the FYI. So this is another common misuse of the device. You want to make sure that you're not torquing your needleless connectors.
Here's the problem with the majority of why your catheter needleless connectors
connectors are stuck. Have you ever had one of these stuck before, where you're like, I can't pull it out, I need pliers to disconnect this? That is because we have been doing this, holding it here at the hub and not at the needleless connector, holding it the... So you want to hold it at the needleless connector, not at the catheter. So make sure you're holding it properly. I'm going to skip over this one. We went over that. 30 seconds. When your nurses are changing your dressings, please make sure they're doing a full 30-second scrub. Don't let them shortcut it. Shortcutting that cleaning process is shortcutting to your infection. So you want to be careful of that. We got secure cath removals. If you have this device, this secure cath device, you don't need this secondary stat lock. It's just going to get in the way. So just ask your nurse not to add that extra securement if you have this orange secure cath. Here's another thing. When you're flushing, this is key. This is also one of the reasons why your catheters are clotting so quickly.
Okay, guys, so I want you to see how much blood ingresses back in, okay? So we're flushing properly. I didn't go all the way to the bottom to compress and decompress the plunger. Look at how much blood came in because of this device.
All I did was disconnect.
So this is why your caps make a difference. Okay.
And the problem with this is you're not going to know. This is a very short catheter with a very large tube. By the time it refluxes all of that blood, it's not getting to where you can see it. And so it's going to reflux where you can't see, and you're going to think everything's fine. So there is a proper clamping sequence, and this is what it is.
Okay, so what you want to do, and I want you to watch because I need you to tell the nurses to do it this way. Okay, have this clamp ready to go. Flush, pulsatile flushing. Okay, and then while I'm flushing a little bit, I want them to lock it while I'm pushing slowly.
Okay, so that's going to be helpful. We talked about catheter pistoning. Make sure your nurses are wearing a mask when they're changing your dressings. If they refuse to, kick them out. Now, you have to figure out your politics of whether you can have other resources, but that agency needs to know that that nurse is not changing the dressing with a mask. That is a high risk for infection. All that breathing, every time we breathe, there's particles leaving our mouth. So it's just a video to explain, how much is actually being spewed out. But please make them wear a mask. If they don't or refuse to, go find somebody else. This is not a COVID thing or a politics thing. This is you're going to infect the patient. And remember, when they leave, if you felt like, hey, I don't know if I can say anything, and they don't wear a mask and they're changing your dressings and they go about their business, when they leave and you get infected, we don't care. Let me rephrase. We don't care. We might feel bad for a moment, but those people who didn't wear their mask in the first place probably will go to bed at night, sleep wonderfully while you're at the hospital dealing with the bloodstream infection. I want you to keep that in mind. We will not care after we leave those doors if you got infected, especially for those of us who refuse to wear a mask, who refuse to collaborate with the patients. So protect yourselves from bad actors, and there are bad actors out there. A lot of us are great, I would love to say, but I have seen for myself bad actors within the companies I've worked with, within the hospitals I've worked with. It's either they don't know, they're still a bad actor, even through ignorance, or they refuse to care. And so you guys really need to protect yourselves from that bad behavior. Most catheters don't rupture, but they can. Here's what it'll look like. So patient said, hey, my shoulder hurt to the nurses, and they said, no, it's fine. Don't worry about it. It's normal. And he's like, nah, I don't think so. So he called me, the guy who put it in, said, hey, I'm feeling this thing. I was like, okay, let me go check it out. So I went to his house, checked it out, found out it was that. It was ruptured like this. It can happen. It's not supposed to. It is considered a manufacturing defect. However, it is something you want to be careful of. If you're feeling any pain or pressure during flushing, get it checked out. Do not ignore it. I think that's a common thing patients do, is ignore that discomfort. They're like, oh, this is something new. It must be a normal thing because I don't know what's normal, what's not normal. You definitely want to get that checked out. These are the different types of clots, so you have an idea
There are 4 common types
of what's
catheter
going on in your
occlusions.
body.
An intraluminal thrombus can form within the catheter lumen. A fibrin tail, the most common type of occlusion, forms when fibrin adheres to the catheter tip. This tail can act as a one-way valve, permitting infusion but not withdrawal of fluid or blood.
This is why you can flush, but you can't draw blood. This is the most common type of clot.
A mural thrombus forms when the fibrin from a vessel wall injury binds to the fibrin.
So when there's damage or friction from the catheter tip for whatever reason, it starts to create and get stuck onto the tissue walls. So there are different types.
So this plastic pot's supposed to be on it.
So the nurse changed his line, I think 3 or 4 times without a needleless connector and left him hanging out there. His line clotted ultimately, but he didn't have that needleless connector and told him it was normal not to have that there and just put a green cap and said it was normal. This is dangerous practice. This hub opened without a needleless connector makes you guys vulnerable for infection significantly. And so you want to get this extension tubing changed out if this happens. Here's an example of a leak. Some of you may have experienced a leaky catheter. This is what's going on.
Look at that. So
look at that tissue expansion.
Look at that.
So that is not a good sign. Do not continue your fluids. If you see leaking, it's a problem. We need to remove it and place a new one somewhere else. Okay? Don't let anybody tell you that leaking is okay. It's not. Get it removed and get it changed out. So we've got some innovative devices. For some of you who are at home, you have to deal with this all the time. How many of you have lost your IV because you accidentally hooked it on something? This is a really interesting device that came out, and I tested it out, and this is what I came up with.
Oh boy, look at this idiot. What was that?
So I thought it was going to come out.
That just came right off.
So dressing's wet.
Huh.
Same dressing, same
What's he doing now?
catheter.
Oh, look at those cheeks. Wait a second.
So
Fall off.
especially for pediatric patients, this is a great thing. They can continue to play, be a little bit more aggressive, and their IVs will less likely get pulled out while they're being infused. So this is a really great, fantastic friggin' innovation. Here's another one. How many of you have issues with your dressing? I think a lot of people with chronic illness have issues with the dressing, having allergy reactions or bad reactions to the skin.
All right, so here we have a patient who has hypersensitivity and possibly shearing.
So you can see that rash right here, and she only had this catheter in for about 2 or 3 days, and it was with the IV3000. The IV3000 has acrylic adhesive on there. A lot of people who are allergic to the Tegaderm, if you're truly having allergic reactions, it is not. The IV3000 may have a softer, more diluted version of the acrylic, but it's still acrylic. You may be allergic to acrylic, so get that tested to see if that's true, because there are a lot of dressings, a lot of wound care products that are acrylic based, and you're just going to have problems all around. So if you are truly allergic to acrylic, you want to avoid those products and use these instead. This is my go-to product for my dysautonomia patients, with those who have allergies to any tape. I use this exclusively. This or Mepilex. If I can get a hold of a Mepilex, I'll get it, but they're not rated for central line catheter dressings. So these are silicone-based dressings. The IV Clear has silver and chlorhexidine, so if you want that antimicrobial, you're not allergic to any of these, it's a great alternative. However, if you're allergic to CHG or silver, the Cova Clear is solely silicone based without any antimicrobial effect. But I have seen these work so well for my dysautonomia patients, and I want the word to get out because so many people are suffering. I'm hoping that these products will be a great alternative for you guys out there.
And I have to do my due diligence and just say that this is just information about products that exist and only
Yes,
doesn't endorse the use of one dressing over another. So I just
yes.
have to make sure that
No,
that's
no, no,
noted out
exactly. Look,
there.
if
So here we have a patient.
I appreciate that. If
All right, so
if
here we have a
the other
patient
products
who
work
has
for you, great, but
All right, so here
what
we
I'm
have a
trying to say
patient
is
who
that there are
has
alternatives, and these
hypersensitivity
have just worked for my patients. If you find other alternatives, fantastic, but I want you guys to go look for it. Does that make sense? There are products out there that could help. And if you don't know, ask around. So these are an example of like an adhesive um, glue. It's not glue. It helps the adhesive of the soft silicones to um, to adhere better. Because the silicone
All right,
dressings,
so
the
here we
problem
have a
with
patient
these
who has
is that they
hypersensitivity.
have very soft adhesive. So it's more difficult to stick by themselves. So I use something to help it stay on for longer because I don't want to have to deal with the patient's uh, dressing being disrupted before the 7 days dressing change. And then another solvent to remove it without causing pain. Because I'm sure some of you have seen and felt the the tape adherence or the tegaderm like ripping your skin off a little bit for some of you with sensitive skin, and so that solvent or that remover will help to dissolve that adhesive. So here's another example of
Bubbles on the okay. Great blood return, nice flush. Any pain? No, no, very good. I'm gonna show you guys something interesting. I don't know if you can see it very well. You guys see those bubbles on
so
those
this is why
small
your
bubbles
clamping
on the
sequence is key.
in the tubing?
Okay. So you want to make sure that they're not moving so much. And so when you're clean, I want you guys also to see and understand pistoning, how to prevent that as best as possible. So this is one
Now
thing
I'm
that
gonna
we
show you guys
use,
about the silver
and I
dressing.
think
This
there's
is where the hypersensitivity
cyanoacrylate,
comes. This
but
is
now I can
now
use it
you guys about the
and
silver
clean without worrying about that going in and out. So there's a couple of other products out there that can help with that. This is another resource. I think there's another ah, Cavi something. There are companies out there that will help you to find the products that work out for certain demographics. And so I want you to know there are resources out there for you. If you're new to your disease, if you're new to your pathology, there are so many passionate people out there that are trying to solve these issues. They're out there. I'm sure you guys are in some of your Facebook community groups or Slack groups, if that's a thing. So ask around. There's a lot of people who are passionate about getting the word out for alternatives because right now at the hospitals, we don't know what can help you out or not. Lastly, I want to close with this communicating with and navigating the politics of uh, the healthcare workers. I'm sure you guys have pulled your hair out trying to figure out how to get resources, or your providers are not not working with you, and it feels like they're working against you. So I want to help you guys get an overview of how to navigate the politics. I'm sure you've seen something like this where you are a difficult patient for an IV, and then they did end up just stabbing you with a bunch of IV needles. So how do you tell if they're going to be helpful when you first work with them, when you first meet them? What I've been told by those who have found successfully after multiple tries, after multiple providers, after multiple consults, they have all come to the same conclusion about if the clinician is curious about your disease process, if they're curious about what works for you, if they're curious about how you deal with it or what you're experiencing, those will get, it's an indicator to let you know that that clinician is probably going to be helpful for you and advocate for you. When you find a clinician that ignores those things, that are rushing and are not inquisitive about your disease process, what works for you, what doesn't, if they're not investigating with you, because it's your experience, it's your disease, and for some of us out there, it's a rare disease, and they're not going to know the answer because they don't do the research. And you're the one that did the research, and so it's up to you to educate. But if they're not willing to listen to you or even consider what you have to say and what you know, then there's a good chance that they're going to ignore you all the way through. And so if you're looking for second opinions, or if you're looking around, shopping around for providers, that's the first thing I would recommend, is see if they're inquisitive about your process, about your disease, about your body. So then how do you advocate for yourself? That's a very difficult one, because every institution, every healthcare system is a little different. If your immediate clinician that you're in contact with are ignoring your pleas, ignoring your requests, there's a chain of command, and you can keep going up that command. I know it can be exhausting sometimes, but if you're going to the same hospital, or there's only one hospital where you're at, and everything else is like 3 hours away. So if there's only one hospital that you can go to, or there's one hospital that you like to go to, then I highly recommend you guys understand their corporate structure. And you can Google some of this. Some of their corporate structure is online. And so hospital, corporate structure or management structure, you can try to find what are the levels of authority, and you can try to hop over, like let's say a charge nurse is not listening on that unit, then move up, escalate if you need to. Remember, when we as clinicians go home, some of us do worry, but most of us don't think about you when we go home. We don't want to think about anything because it was most likely a rough shift. It's work. We want to clock in, clock out. Whatever the reason is, we don't think about you guys for the most part. Sometimes I do. There's patients that I follow up with 6 months. Like right now, I have one that I'm following up with for the last 6 months. But otherwise, unless it's a rare case, we cannot think about every patient when we go home. It'll be very toxic and very unhealthy for us. But you guys have to deal with our actions. You guys have to deal with our good practices and our poor practices. And so I think it's very important for you guys to advocate for yourself and escalate when you need to, because you're going to be in that hospital bed, not getting good sleep, still infected, still this, still that. And the nurse or the doctor could have been just looking out for their own convenience. So that is a thing, and I want you guys to be aware of that. So yeah, any questions?
I think as we start to wrap up, first of all, that's so real. And we at Oley do a ton of work on helping folks develop those self-advocacy skills and feeling confident enough to ask the right questions, say no, move up the food chain. And there's quite a few other, patient advocacy organizations. So just so if you are in a position where you have to do that, you're not alone in that way. And we're happy to support you through that. I think one that came up a couple of times, we have a lot of long-term CVAD owners. Is there a shelf life or an expiration date on a line if you continue to use it with no complications? I know some folks ask to replace it just because it's old. What are your thoughts on that?
I love it. That's a great question. It's also a complicated question. Let's start with PIVs, and then let's do CVADs. Forget PIVs. Actually, I kind of want to. Do you mind if I talk about PIVs, because it will deal with you guys?
Sure.
There is no expiration date. The plastic doesn't go bad after. Patients have had their Hickman, their tunneled lines, for 10 years. Swapna, fantastic advocate for chronic illness, especially for GI. She's had her line for 10 years, but she also took really good care of it. Her mom and dad were the ones to help her change that dressing when need be, and take care of that line. She made sure that she took care of it herself, masked up, did all the proper cleaning techniques. She was also involved in the AVA organization, the Association for Vascular Access. So she got her information and her skills directly from the source, from us. And so she attended these conferences. She also networked herself in and educated herself on the best practices for these lines. And so she was able to take it. And there's a lot of other people who have mastered this CVAD thing and how to take care of it. So it can last a very long time. The recommendation is change out that catheter, remove it when clinically indicated. When there's a problem, that's when you remove it or replace it. Otherwise, if you need it, we keep it in there. I know infectious disease, some have different opinions about that. They think that the catheter itself will be a vector, or microbes will latch on to the catheter and start culturing. There are some organisms off the top of my head. I can't remember all of them, but there are types of bacteria that do like to stick onto plastic and polyurethane, but they're usually human error, meaning we injected it in there. So when we didn't clean that hub properly and we're talking and letting all that junk spill onto the hub, and we inject, we don't clean properly, we don't let it dry properly, all those things, we push that bacteria in, and that's when it started to adhere. So the infection is usually because of us and how we mishandle it. But otherwise, the plastic itself does not degrade. It does not go bad. I believe silicone, so Hickman's and Groschon's, I believe, are silicone. Don't quote me on that. I don't know if the manufacturers change their materials, but generally they're made out of silicone. And silicone has a higher rate of breaking. And so they break so often that they sell repair kits for it. The polyurethane catheters generally do not break. They only break if there's a defect, if there's a manufacturing problem. But in design, they're not going to break.
Awesome.
That's a great question.
Yeah, thank you. You answered that perfectly. So we have about, 7 more minutes. Do you have any, I know a lot of us have been talking this week about sort of the long-term vascular access preservation. Is there anything we can do as patients, or any, I don't want to say recommendations, but any thoughts you have just about how we can sort of maintain our vascular acreage to the best of our ability, and what we should look out for and make sure?
Yes. Oh, vessel preservation. Let's talk about venous depletion. Every time we poke through your veins, it's getting scarred. I don't want to deter people from donating blood, but if you're donating blood like bi-weekly, weekly, monthly, or however frequency it is, you're scarring that vein every time. And they're not using small needles either. They're using huge needles. And every time they miss and have to poke you again, that's just another extra scarring opportunity. For you guys, because of your chronic illness, you're in there frequently and you're going to get poked frequently. We're talking blood draws. We're talking IVs for just hydration or what have you. So minimizing that trauma is going to be important for the rest of your life, because you're going to have to deal with this frequently. Consider this. We as clinicians generally don't have your disease. We don't have these chronic illnesses generally. I'm sure there's a lot of great clinicians out there that have the same issues, and I know a few that do. I know great nurses that have EDS. I know great nurses that have MECFS and MCS and GI disruption disorders and things like that, colostomy bags and whatever, and they still work. But that's not the general population, and so we do not initially empathize with your venous preservation issue. We don't think about it, because when we see our patients, usually, especially in the ER, we only see you once ever. And we don't know what it feels like to get poked a bunch of times. And so you may have to use that as an angle of attack to get them to advocate for yourself. This is an example of something that you can use to, not a recommendation, but let's say hypothetically, they poke you a bunch of times, or you know you're going to get poked because you know you're a difficult stick. What we call is a known diva. And through the AMIC study, she, at her ER, she's quantified that a diva patient, a difficult IV access patient, will be 4 times more likely to get poked multiple times. We know this. We've quantified it. So if you're a known difficult IV access patient, then we're going to poke you a bunch of times. So let's skip all that rigmarole and get that ultrasound and get you in one poke. Now, how do you advocate for that? You have to get them to empathize with your situation. Okay, I'll let you poke. You say this policy. You have to poke me 2 times, and then you have to get your friend to poke you 2 times, and then a third person has to poke you 2 times before you even go look for the ultrasound. That's your policy. Okay, I get it. You don't want to get in trouble. How about this? If you don't get the ultrasound, every time you miss, I get to take a needle and poke you myself. How about that? Not that you're actually going to do it, but bring up that deal to negotiate their brain to put themselves in your shoes. Oh, I guess I don't want to get poked 6 times. I get it. Okay. Hopefully that'll get them to consider or reconsider poking you 6 times, because we're not empathetic. We don't know what it feels like. We don't know what you're going through. Generally, some people will, I will, but most of us don't experience that. And so negotiate from their empathy somehow to let them understand, hey, do you understand you're shanking through my skin 6 times before you're agreeing to use a tool that will help you get that IV? Like, why would you not use that tool when you know I'm going to have a problem? So pull on their empathy strings a little bit and figure out how to get them in your shoes. There are, just a little insight, there are policies in place that prevent nurses, for whatever the effing reason, to use the ultrasound. So, case in point, I know floor nurses who got written up, got in trouble because they called the vascular access team. The vascular access team wrote them up because the nurse didn't try on that patient that they knew they were going to have a problem with. People are risking their not their license, they're risking their job to get that ultrasound for you. So understand that. And so whether you escalate that to the management level, like, hey, your nurses are getting in trouble and telling me that they're going to get in trouble for not poking me twice. I'm a known difficult IV access. Why the hell is your hospital policy telling them to torture me before they poke me? Here's another thing. This is a recommendation, actually. Maybe not a recommendation. Let's say this. If you walk away, and an insight, if you walk away against medical advice, our hands are completely clean of having to do anything for you. So you have to be careful what you say when the nurses or physicians are reiterating what you're saying. This is a little game that some of us play, and I've played it too before. I'm completely ashamed of it. If you say, I refuse this and that, and we reiterate, are you refusing care? And in your or our care, and in your frustration, you said, yes, I'm refusing. When you meant, I'm refusing the multiple pokes, but the way you said it and the way we reiterated and you confirmed will now wash our hands of having to do anything for you. So keep that in mind. Be very careful. This isn't all the time. However, they will document that patient refused care, and then that covers us legally from having to do things for you or continue that care in certain manners. So be careful what you say. And so here's what I tell patients. When they refuse to listen to you, say this. Before they poke you, say this. I am not refusing treatment. I'm not refusing care. You have to say those words. I think this medication will help me. I think you guys have the best thing for me. I think your treatment plan is going to make me better. And I'm hoping that I will get better through your care. However, I am refusing torture. I've been through this every time I come to this damn hospital. You guys poke me 6 times before you get the ultrasound. I'm sick of you torturing me. So yes, I am refusing torture, but no, I am not refusing care. Once you say that, you bind their hands. They can't go back and document that patient refused care. Now we don't have to do things. And so keep that in mind. Also keep in mind, if they're like, no, we're going to do it anyways, and then they hold you down and poke you, that's a criminal assault, and you should charge people. You should file a complaint, and you should charge file a charge for that. That is a criminal assault. And so I just want you guys to know, you guys have power in your hands. Just understand what authority you have. You have to protect yourself. There's a lot of bad actors out there. And so I have a soft spot for my chronic illness patients because you're the problem I have a hard time solving. And so I'm still trying to figure it out. I'm trying to solve these issues. But just know you have a lot more authority in your hands. You just have to understand how to play the game.
Thank you. Thank you. I know you totally, you're one of the ones who get it. And sometimes it is, more often than not, it's an uphill battle, but we are a resource. And like I said, there are so many patient advocacy organizations that can help you figure out what that language is to get what you need and not be the difficult patient, and be really careful with that. So thank you so much for your time and your expertise and sharing all of these questions, or answering all these questions. Did you want people to reach out to you with questions? Do you want them to go through
No,
us?
go for it. So
Okay.
basically, it's easy. thevascularguy@gmail.com. Send me emails. I don't know if I can answer, but I'll give you resources. The Oley Foundation exists. You guys have a resource. Like they will understand more on how to navigate the patient side than I can. Because I honestly, I've never been a patient at the hospital before. So I don't know all the tricks. I only know from my end and what we're doing to block you guys. And I'm hoping that that the Oley Foundation will give you more insight on how to advocate and how to get resourced. So yeah, get plugged in, guys. This is the place to be.
We will absolutely do that. And speaking of plugs, I'm going to make a final plug for our call for speaker submissions for our conference this summer, June 17th to 20th in Charleston. Dennis, I don't know what you're doing, but we would love to hear from you again. See you in person, maybe.
Screenshot that.
Perfect. There's a QR code. I think that'll take you to our website. Thank you again so much. Like I said, we do have a ton more events this week. I'm making sure there's nothing I'm missing. The recording of this event will be on our website at oley.org/webinars. And we'll continue to post all of our events on our social media channels, Facebook, Instagram. We're not as cool as Dennis. We're not on TikTok super actively yet. We've got a couple of things up there, but thank you so much to everyone who attended. And thank you so much to Dennis and Blaine for your time and for sharing your expertise with our members. So it was a real honor to be able to get you.
Oh, it was an honor for being asked to be here. I really, really am blessed that you guys asked. So I appreciate that.
Awesome. Well, with that, I will wrap up. A lot of thank yous in the chat. Awesome. Have a great rest of your day, everyone. Thank you so much.